Okay, we're going to begin going through basic mandates starting with 100 section. And this is the beginning of you knowing if you're ready to do this, all right, and how much commitment you want to put to it. 100.10.5, there must be a written screening protocol for venous thromboembolism, VTE risk placed in a medical record of each surgical patient. The protocol and assessment tool is be placed in the facility manual for reference. So I'm certain that everybody has seen one of these before and that you probably already have it in your clinic. If you don't, I can help point you to a resource for that. And anesthesia probably has one of these checklists. So I would ask anesthesia, since they do this as a regular double check anyway. So you would need one of these reports, and on your thing in here, you would write where it is. So if it's on anesthesia card in a binder, that's where it is, okay? But the masters are there. So this should be part of your patient chart. So scan in, get this uploaded to your patient chart so that you can do the checklist on it. Point 10, we're gonna do, the facility should have a scheduling policy that includes only those procedures and or a combination of procedures and the duration. How long does the surgery normally take for that type of procedure? And the degree that permits safe recovery and discharge from the facility. So you want to confirm that you're going to be able to recover these patients just fine, and about how long, traditionally it normally takes, right? I've seen OR surgical techs, because they're, the nurses are charting and OR wants to move, but it's a surgical tech starts flipping the OR, then you have to make sure that somebody's watching these patients and they're not rushing them out because somebody has to go do something that evening or whatever. You have to wait. It has to be patient safety guided, okay? A preoperative surgical safety checklist should be used for each patient and noted on the record. Usually that's in the OR circulation paperwork. I do have something that came from WHO a while ago. And let's see if I can zoom out. I like this checklist because, look at, turn on my light here. So the patient, right? So sign in. This is just what you do in the hospital, right? Doctor, anesthesia, pulse ox on the patient, allergies, right? And then it goes to before skin incision, the timeouts. You need your board in your OR, dry erase board. Your nurses know what you want, or sometimes the providers can even present the way that they like to do it. But this is for record keeping, and usually the circulating RN and anesthesia will remind you to call timeout for everything. If the doctors remember, that's even more great, because that means you're all in your zone. All right, here we go. This is what should be on your list. And then before patient leaves the OR. So this isn't even to backpack you. This is for coming in, right? Nurse verbally confirms with the team. Okay. And again, it's not a comprehensive checklist, and I got it from WHO. Okay, so you can head out there. It's called the Surgical Safety Checklist. I don't know what edition they're on right now. This is something that I carry around and I share with the teams. I used to put it up at my ORs as well, right? So it'd be on the wall in my ORs. Next is patients receiving anesthesia or anesthetic agents other than topical or local should be supervised in the immediate post-discharge period by a responsible adult for at least 12 to 24 hours. So Medicare, this was a great big deal. And I would think with COVID, I don't know what the urgency is to exit patients right now. But they need to know with a discharge document, side effects, swelling, right? Inflammation is like the number one of everything, everywhere for recurring and redressing, right? because it's too tight for inflammation. Icing is really important after post-op. So chillers are very important, and they're supposed to have a responsible adult picking this up. I think this is so somebody can't just jump in a taxi cab and go home from there, right? So by responsible adult, I know you have to be 18, right? That's considered an adult. So if it's a kid that's 16 and driving, if they present their age as 16, that won't be a legal discharge, okay? So the person needs to be 18, and then who's going to watch the patient at home, and what are the rules? Patient, coming out of anesthesia, they don't always follow their guidelines because they don't know. Guidelines are as important as you make them to the patient and their family, okay? I'd say the better your post-op discharge guidelines are, and the more that's in writing so that they can refer when they're, coherent, as best they can be, what to watch out for. The big guidance on this is websites, right? If you're practicing in your specialty and you have an OR in your specialty, this type of accreditation, it's not mandated to have a website. The Medicare ones were mandated to have a patient website, and the best part for the website is that all of the documentation that you would send, so you had surgery, whatever, that kind of thing, here's what you do, right? Here's, trip ups that may happen, here's easy, that kind of thing. So consider your consents and stuff like that and discharge paperwork on your website. That way they know what was done to them, because a lot of people don't even know, they just go to surgery. If they can think about where their surgery was and exactly what had happened within their surgery, right, they can focus to help heal and feel better and need less pain medicine, right? Because pain medicine, in my opinion, has patients do more than they probably should because they don't feel the pain of it and they're not focusing on it. They're focusing on the pain and getting rid of it. All right, so you guys are the docs. I'm admin, but I've had to help wean and present to the physicians, right? Weaning needs and stuff like that from patient interactions. Okay, number 20, changes in the facility ownership must be reported to the Quad ASF within 30 days of the change. They vet, the owners to make sure everybody is, what do you want to say? Based on the credential, there's liability here, right? So you want to make sure that everybody is accountable, and if someone's going to be accountable on your number, right? It would be just like somebody driving your car, and they got in an accident, right? So you want to know. Any death occurring in an accredited facility or any death occurring within 30 days of a surgical procedure performed in an accredited facility must be reported to Quad A within 5 days after the facility is notified. So post-op, if somebody had a comorbidity that didn't work well, you need to make sure that you're documenting and charting, and your physician's return to clinic office visits, right? Your post-op visit, anything. And everybody already knows CYA. With patient, saying what is going on in their life. We all know stress has a big deal, and anxiety, and if they're overworking and not following doctor's orders. Correct anything that you can just to avoid this. In addition to this notification, the death must be reported as an unanticipated operative sequela in the semi-annual peer review report. In the event of a death occurring within 30 days of the operation done in a Quad A accredited facility, an unannounced survey will be done by senior surveyor unless waived by the investigative committee. So they will pull the records and, like when the patient calls, all that kind of stuff. So if patient calls in, that should be reported in their chart. If they call in about complications or what they consider as a complication, right? what's a complication, right? Complication is that they don't know what's going on, and they probably did something that they weren't aware they weren't supposed to do. Memory retention isn't great, so that's the benefit of dictation and taking care of your notes on your side. So you can have it waived, and that's very simple to do. So Quad A, their gold standard, they do understand, all right, and they already know. So they'll know by your chart. They read your charts when you submit them. They have the auditors, right? So they know everybody. They know, just like people know our handwriting, right? Okay, number 30. All individuals using the facility must meet one of the following criteria throughout this document. The terms physician, medicine, and medical apply to an MD, a DO, and DPMs. Okay? A doctor of medicine or eligible for certification by one of the member boards of the American Board, sorry, I looked away, of Medical Specialty, ABMS. A doctor of osteopathy, certified or eligible for certification. So to be a practicing physician, you notice they're saying certified or eligible for certification, right, on the board. So you do get your, you have your 2-year pre-board term, so to send in your cases on. So anyone that is pre-board can also operate in your OR, as long as they present their board cert that they have applied for it and where they're practicing. So AAAASF, and then podiatrist certified or eligible for certification by the ABFAS or the ABPM. Oral and maxillofacial surgeon are eligible for certification by the ABOMS. All right, so you just have to, anybody that's operating has to be qualified to be a surgeon, okay, if you're using the OR, okay, this accredited OR. All right, number 32, the facility director is responsible for establishing and enforcing the policies that protect the patients. So facility director, again, is whose butt is on the line, okay? So usually it's the owner and the operator of the surgical facility. I have not done hospital type of credentials, so I don't understand the hierarchy for that. But regarding Quad ASF and outpatient surgery centers, you hold all, if something happens, and right, so which takes you to insurance, right? You're going to need insurance for your facility. The director monitors all members of the medical and facility staff for compliance with this policy, which I have policies to protect, so we can go through those and refer back to this section here. This is a general review. 0.35, every physician, podiatrist, oral and maxillofacial surgeon opening a Quad A accredited facility must hold and must demonstrate that they have held unrestricted hospital privileges in their specialty at an accredited or licensed acute care hospital within 30 minutes of this facility for all operations that they perform within the facility. Only surgical procedures included in those hospital privileges may be performed within a Quad A accredited facility. So a physician must be present when anesthesia, other than strictly local, is being administered, okay? And facilities accredited under Class B, CM, or Class C. So when anesthesia is pushed, the physician has to be on site to begin the procedure, right? So no anesthesia unless it's local to be there. All right. And then they want you to have a transfer agreement with your hospital, your nearest hospital that you're on board with. They like 30 minutes just to get the patient, because the ambulance can, I believe, handle a 30-minute transfer. You're probably going to need an ambulance agreement and phone number in here. Not probably, you will. Just to handle that part. Okay, and we're going to go to on-site. Here we go. All right, so on-site Quad A surveys typically involve the attention of the facility medical director, the anesthesia provider, and the facility staff working intently with the Quad ASF surveyors. I have seen anesthesia pop in and pop out. I've seen anesthesia after, I guess it's based on how many surgery centers and how you know protocol, how long the anesthesia has to be there. Let's see. The survey process must remain focused, and therefore Quad ASF has directed that equipment representatives not be present during the announced or unannounced surveys. So if you're busy, you have to drop everything. When it's your final accreditation survey, you will have, I think they try to give you like a 10-day notice so that you can have your charts, make sure everything's all set up. So they don't want anybody there. And like I said, anesthesia, if you do have your anesthesia, it looks like they can just pop in and do their part and then pop out, right? Because it's Section 900. Accreditation consultants may be present during the surveys. However, Quad A asks the consultants remain silent during the process until it is completed. And that is to help the staff realize the importance and where their stuff is. All Quad A surveyors have the authority to request any participants leave the survey process if interference becomes a problem. Quad A greatly appreciates all concerned parties' cooperation in complying with this directive. Number 45. There we go. Class A. Oral, this is kind of easy. Class A facility, no more than 500 cc's of aspirate should be removed when performing lipossuctions. They must meet all. So this is nitrous, right? All right. Let's see. Class B, this is where we went through our classes, right? And then Class C, I read in the last module. And let's see, what else do we have here? There we go. So they're talking about the board, ABMS certified or eligible medical specialists who perform surgical procedures within the accredited facility may perform only those surgical procedures delineated in their ABMS board certification. Your delineation of privileges, all right? Just so you know. And, you can also use your own surgery center as an area that you are a staff member with your delineation of privileges, right? So it's having all your board certifications within the facility. The core principle number 7 from the AMA resolution dated April 2003. And they worded it out for us so we don't have to go look it up. Okay, the core principle, physicians performing off-based surgery must currently board certified, qualified, or by one of the boards recognized by the ABMS, AOA, or the equivalent standards approved by the state medical board. The surgery must be one that is generally recognized by that certifying board of falling within the scope of the training and practice of the physician providing the care, right? Physician's hospital has the right to limit the type of procedures the physician may perform within the specified scope of practice. Granting hospital privileges outside of the scope of training and practice recognized by the individual practitioner certifying board will not apply to the Quad A accredited facility. Okay, so let's see, number 70. Practitioners of pain management would be required to meet the following. They have to have an MD or DO, appropriate fellowship, training in pain management. They have to possess ABMS board certification in their specialty, anesthesia, physical medicine, and rehab, or psychiatry and neurology. Possess a subspecialty certification from the AAAASF, all physicians practicing in Quad ASF facility must hold or demonstrate that they have held unrestricted hospital privileges in their specialty, right? And again, within 30 minutes of the accredited facility for all procedures. So you're going to be able to just say what the procedure was, right? They'll want the codes, anything you can send over. So the importance of dictating ASAP and charting and signing off everything is very important. This one, here we go, number 75, practitioners of interventional radiology must meet all of the following criteria: MD or DO, board certification or board eligibility by the American Board of Radiology, fellowship training approved by the ABR, current certificate added qualifications for the interventional vascular radiology. All physicians practicing in the Quad A must hold or must demonstrate they've held, again, their hospital privileges. And I'd say the interventional radiology is mostly pain, right? The C-arms. So whoever's running your C-arm, right? You want to make sure is certified and trained on running their C-arm. And if you have a C-arm, you're going to have to present documentation, or you may have to present documentation or be prepared to. Licensed anesthesia providers supervising or providing care in the facility should participate in the QA and risk management of the facility. I would say anesthesia is more important than they're probably given. Yes, they put our people under and wake them back up, but anesthesia also can recommend. So RNs, when you are doing your patient charts, scribble something, and the anesthesia does give you an improvement, scribble it down so that you have it for your quad survey. Find, your spot where you need to write down an improvement in a product, item, procedure, right? That your anesthesia recommends that you do, right? How to dump something, anything that they give you guidance on, because everyone's taking their CMEs, right? And we all learn something new every year, right? So there's new tech, there's new thoughts, ideas, right? Programs. All right. So yes, I would count anesthesia on your list for doing your assessment, especially now since I see they named the peer review to the anesthesia review. A patient who, by reason of pre-existing or other medical conditions, is at significant risk for outpatient surgery in this facility should be referred to an alternative facility. And I think everyone's had that, where they've had to do the surgery at a hospital instead of at their own facility for the risk, right? You have more help. You have the ER. If for anybody with the comorbidities, if you're not comfortable, you'll get a gut feeling, right? And that's the part of you diagnosing and determining the need and how, what, why. And I think hospital, you might be able to aspirate more for plastic, but I don't know their guidelines. Again, like I said, I'm just I'm outpatient surgery. So your risk, or your patient, your risk, and their risk as well, right? So you want everybody to come out of it and be happy and be improved and not have to worry about unanticipated sequelae or somebody losing their life, right? So, all right, here we go. Thank you.